So I'm happy to call for Camille Thomassin, who is the co-chair at HTA Coordination Group for GCA and HTA department at HAS. Thank you for being with us.
Thank you. Thank you very much, and good morning to all. So today I will present you a brief status update on where we are on joint clinical assessment. I assume that you have also some discussion yesterday on the evolution of GCA as we are. So I will be brief on some parts, but don't hesitate to ask questions after the presentation or during the morning. So may I have? Yes. So here is a slide just to show you the different steps when we are talking about joint clinical assessment and where we are positioned. So the process is supposed to be in parallel of the regulatory process at EMA. So the regulatory approval will deal with how the technology works and does the technology work? Does the benefit of the technology outweigh the risk? And are there any additional needs for post-licensing evidence generation? Then, as you all know, it's a single licensing system for the centralized procedure. Under one EU legislation. And then since the HTA regulation has been adopted, then the products are the subjects to health technology assessment also in a collaborative level. So in each GCA, you will find the relative assessment of the technology X versus the technology Y and versus other technologies if it's relevant. And so the objective is to determine how it compares to what is already available on the market for the European Union level. Then I just want to insist on some points. So we are here dealing also only with clinical domains. So there is no conclusion and no value judgment in that approach. It's a common methodology approach because you have seen many guidances that have been adopted by the HTA Coordination Group in the past few months, and some are still coming, for example, for the medical devices. So these methodological guidances have been developed by the member states in the format of a working group. So they are really taking into account the methodological perspective of all member states. And then you have the national step after the joint clinical assessment. So that's why we are calling the appraisal phase. And during this appraisal phase, of course, you will have additional consideration taken into account depending on national context. Then to go to the decision of reimbursement and the pricing. So in all this system, what has been agreed on in the legislation is that the GCA should be given due consideration during each national decision making, and there will be an evaluation of how the GCAs are included and taken into consideration in the national process. So it's part of the evaluation of the regulation to show how each member state will have taken into consideration this GCA. So it's really important also at national level that we are prepared also to incorporate this GCA in our national process and to show how we will use it and take it into consideration. So here is a brief update of where we are on the ongoing GCA for medicinal products. So you can find information on the European Commission website. I've put the link here. So you have the information of the ongoing GCAs. One, they are validated by the European Medicine Agency and published on their website for the starting of the centralized procedure. And once we have appointed assessor and co-assessor from our side. So it's a double conditions to be published on this list. Just a few reminders, the joint HTA reports, so they are led by 2 European member states, and then it's based on one HTD submission dossier submit to the HTA Secretariat at European Commission level. So the data that have been submitted at EU level are not resubmitted again at national level, but national entities can ask for additional data if they have not been submitted at EU level. So as I previously said, the work is focusing on the clinical domains. There is no value judgment, and the member states have to give due consideration. So the whole aim of the regulation is to avoid duplication of the work, is to increase the consistency and the quality of assessment across Europe. And then the ultimate goal is to facilitate the patient access across Europe. Then for the moment, we have scope that is limited to new active substance in oncology and to ATMP. I think there is a mistake on the slide, sorry. Then we will have GCA on orphan in 2028, and then we will have the full scope in 2030. Then we can also include type 2 variation once the GCA have been published on the initial indication. So maybe it will arrive in 2026 that we will have the first GCA for type 2 variations. And for the medical devices, so the scope is the high-risk medical devices, the type 2B and 3, and IVD. So for now, what is planned is to start in 2026. The work program for the HTA coordination group has not been delivered yet, but it will be validated by the coordination group end of November. So you will have more details at that moment when we will adopt the work program. But as I can say, we are still on track for 2026. So here is a brief summary of what is ongoing with the assessor and co-assessor involved and the status. So you can see that for some dossier, the assessment scope explanation meeting we planned with the HTD have already taken place. Here at the bottom of the list, so you have the dossier that is arrived recently. So now we have also 2 dossiers that have been received from HTD, the first 2 dossiers, and they are currently under confirmation check by the European Commission. So I won't go into detail here, but just to show that we are really in parallel of the timelines of the EMA. And just also to touch upon one thing is that in the regulation it is planned that we can also adapt to some steps that are taken place in the EMA process in the way that there is exchanges between EMA and the HTA Secretariat, for example, about some parts of the list of questions that are received by the HTD. If these questions are have a probability to influence also the indication that will be delivered at the end, so we are informed of some insight of the CHMP. So that's, for the moment, it's difficult to tell how this information are useful in the process. We will tell after several GCA, but it's really appreciated by the teams to receive the information at crucial steps from the CHMP. Just to precise also that we are not receiving the report from the CHMP. We are receiving parts of the list of questions. and also we are aware of any change in terms of timelines. We are aware by the EMA. So it's also something important for organization of our work at HTA level. So here is a brief update on how we involved experts in these GCAs. So our goal is really to co-create the involvement of patient and clinical experts in the process. So that's why a working group for the identification of patient and clinical experts has been launched. This working group is within the Health Technology Assessment Stakeholder Network that you may know. So just to precise that the identification of the individual experts is performed by the HTA Secretariat of the European Commission. They are also checking the conflict of interest for the potential individual experts. And then after that, they are presenting the list to the GCA subgroup. And then it's the GCA subgroup that will select the experts, so the clinical expert and the patient expert. And usually we select a maximum of 2 clinician experts and patient experts, depending on the indication and the need that is expressed by the member states. And also to take into account the fact that one expert might not be available during the process, so it's great to have also 2 experts on board in case of that. So the expert can comment the consolidated scope before it's finalized. It may seem like it's late, I know, I've already heard that, but the thing is, before the scope is finalized, we can still modify it. So I want also to reassure that it might seem late, but we have still the opportunity to modify the scope. We have discussion in the GCA subgroup meetings to review the comments from the expert, from the patient, from the clinicians. So we have the opportunity to modify the scope. It's not late, although we all wanted also to involve experts earlier in the process, for example, before proposing the scope for survey to all member states. So we are working on that, and I hope that we will be able to involve experts earlier in the process, but just now it's already very useful. Then the experts comment also the revised draft report. Just to mention that the 5th meeting of the stakeholder network was held in 1st of July in Brussels, so you can already find some information on the website of the European Commission, and we had recent stakeholder networks in October, so last week. So I don't think information are already published yet, but it should come soon. And also, we have a webinar for patient and clinical experts that is available on the European Commission website if you want to look at it. And so just, I think it's my last slide. I wanted also to share some key takeaways. So it's for the health technology developer, and it's based on our first experiences on the dossier. So one alert is that you should always think of submit the letter of intent and provide updates in due time, because it's really important for us that we are keeping up to date in what is happening from the regulatory side. Especially updates on the planned date of submission to EMA, because we know that in the first letter of intent there is always a planned date, but we know that it can be modified with time, and so we really want to have this information as soon as possible to plan for resources. It's really important. So please also be proactive in submission to HTA Secretariat for the SMPC and clinical overview. So we want to have this information at the same time as EMA, because this information also are important for drafting the scope. So we want to receive it in due time. Because the scope, as I want to remember, the scope is based on the indication. So we are taking the precise indication that is in the SMPC. So we are not taking the indication that is in the letter of intent. We are really taking the indication from the SMPC. So it's important that we have the right indication on time. So I know there is many guidances and legislation for now, but please familiarize with all these guidances. And also we are publishing question and answer document from time to time. So we are also clarifying, implementing things in addition of the guidances. Prepare yourself. It's also a key takeaway, because you can start mapping the PICO landscape in Europe earlier on. So you will be more prepared when you receive the scope validated by the subgroup. We also want to increase the communication, but the communication is increased within company between the regulatory and market access team. We have seen it. It's very important to the efficiency of the system. And then just to remind that we run in parallel to the EMA process, but it's a separate procedure, it's a different dossier. So we are very conscious that HTDs have to familiarize also with the format of the dossier. So we also hope that after several dossiers, we will be able also to work on the templates again, if there is something to modify or to clarify in the template of the dossier. Thank you very much.
Thank you very much. So I begin to worry about the time. Please stay here, because we have less than half an hour and 3 speakers and many questions. So this is a problem. So Monder says that it would be good to ask 2 burning questions now, and then we go to the next speaker, and then if we have time, we go to another questions. Please. François, then Monder, then, okay.
Yes, thank you, Camille. Very clear. Just a question. Nobody indicates what are the expected dates of the ends of the current of the JCA that has started. Of course, there is some uncertainty, but however, it would be very useful to know when we can know exactly what comes out of this process, to know the expected dates for the end and the availability of the joint clinical assessments that have yet started.
So what is published is the table on the EMA website with all the steps depending on the date the HTDs are submitted the dossier. So there is table for the initial dossier, then after each clock stop. So even during the process, it's really difficult either for us or either for the EMA to have a clear view on the end of the process. And I think it's the same thing for HTDs. So I must say that no one has ideas on how it will end. For sure, what we know is the earliest date it could end. So we have this for our planning. So I don't think it's published because it's for our purposes of organization. And then if we publish it, we may have to update it each time. I don't think EMA is publishing either a date for the end of the procedure, so we are not doing it either at the HTA level. So yes, that's why I can say. But I don't know, maybe the HTD will have some insight about it, but it's one of the things that is difficult is that we know we should have some flexibility around the timelines because there will be additional clock stop, there will be scientific advisory groups, so we are accommodating with that on the every day.
Okay.
I would just like to add that having those dates published, in my view, it's commercially sensitive information, because from there you can actually predict when it's expected, the approval, the regulatory approval. That's commercially sensitive information. That's competitive intelligence. So I think that's another reason why probably this information shouldn't be public. Yes, EMA follows pretty defined timetable, but you don't know exactly how long has been the clock stop, when was the restart of the procedure. So I think this information is sensitive.
Yeah, I agree. So yes,
I really begin to worry. So, Momder, could you keep your question for later, because we are not in time, and Jörg is here, so we have to be in time. So please, thank you very much.